So at the moment in 2026, SABR is a guideline recommended option, for example, in the EAU guidelines, the NCCN guidelines, and the NICE guidelines as well. So we do see that this is a standard option that's available, but all of them are recommended for patients who may not be suitable or may not be ideal candidates for surgery. So for the moment, that is still the strongest case and the strongest setting to use this type of new treatment option. Importantly, where it really excels is in those patients who may not be surgical candidates but might have larger tumours, where thermal ablation has got guideline recommendations that should really only be used for tumours up to 3 or 3.5 centimetres for technologies like cryoablation, because the recurrence rates are higher for these type of tumours. Also, some of the tumour locations can be quite complex, for example, closer to the kidney, central part of the kidney, the renal pelvis, in which case thermal ablation also has issues like heat sink effects or damage to the ureter, which means it's not a great technique to use. So SABR, or SBRT, is really useful in those patients that are not surgical candidates, that potentially have really no other options, but it seems to be as good or even comparable or better than the outcomes we're seeing from thermal ablation. So these are the patients that we should be targeting. In the future, it may be that we use these as an adjunct to avoid a radical nephrectomy, a total nephrectomy. So for example, a fit patient that might have had a previous total nephrectomy, the kidney out, and only has a solitary kidney, and they may be medically operable, but perhaps the best option would be SABR SBRT to keep their kidney rather than risk a total loss of their kidneys and going on to dialysis. So this may be a future option as well. We're certainly using that in routine clinical practice at my institution.